surface area was covered in burns, which is a rather severe burn injury. 60% of those burns were partial thickness and 40% were full thickness. She was immediately treated by first removing the damaged tissue, then applying an autograft to the full thickness burns and a biodegradable temporizing matrix to the partial thickness wounds. The partial thickness wounds were also sprayed with a ReCell slurry solution with the hopes that this would stimulate additional tissue cell growth. To give slightly more information on the wound healing application, I'll go ahead and explain the various techniques used. So first, for the full thickness burns, because the epidermis layer is destroyed and some adherent structural components are also destroyed, we have to apply a meshed autograft. The autograft is tissue from a different location of the woman's body, and this technique is a good option because it eliminates the risk of disease transmission and failure to accept the tissue. When the tissue comes from the person's own body rather than a donor, it is typically more likely to be accepted. To get the autograft, a doctor will use a gouglier knife set at an angle to produce the desired thickness. The knife moves back and forth very rapidly and creates a layer of skin that can be peeled off, as you can see in this image right here on the screen. When the tissue is then taken, it's taken off of the person's body and it's meshed and then expanded to cover the wound surface area. And because the dermal layer is damaged, we want to prevent the skin from contracting and being permanently contracted. So what we'll do is we'll create a mesh that's larger than the actual wound area in order to prepare for that slight contraction that is inevitable. The mesh will provide also a scaffold for the tissue to regenerate, and it's applied to these full thickness wounds. One con of this technique is that it is increasing hospitalization time, and there's a higher risk of infection because you are creating additional wounds to the woman's body. Then for our partial thickness wounds, there is damage to the epidermis and partially to the dermis, but not to the bone and muscle. So they can usually be treated by applying a mesh covering to the site that keeps the wound moist, and then it also prevents infection and allows to heal on its own. The biodegradable matrix applied to the patient in this setting was to provide scaffolding for the wound to help facilitate dermis regeneration and cell growth. This particular tissue matrix creates small micro wound segments within the dermis that allow for the body to regenerate in smaller areas over a larger surface in a more organized way, as you can see in this image right here. Because the wound was partial thickness, a spray-on cell solution must be added to the top layer of the skin to maintain moisture and create cell regeneration for the epidermis layer. The ReCell that was then applied was to promote epidermal skin cells by spraying on a suspension of the patient's own cells to the wound, as you can see in this image here. For the ReCell, the cells have to come from the patient's own body, otherwise the layer of skin is going to be discolored or the patient will just completely reject the donor tissue cells. It's also important to note that this process is usually done completely in the OR suite, so there is less handling from various doctors and engineers, and there's less transfer for this process. This prevents infection and damage to the cells as well. However, the technique for partial thickness wounds was not effective, and what we found was that there was not uniform reepithelialization, and there's also significant open sites with no visible keratinocytes on the person's partial thickness wound sites, which we cannot have. So there are many reasons why the partial thickness treatment failed or could have failed. The uneven healing could be due in part to the fact that the biodegradable matrix creates micro wounds that section the dermis into more organized compartments. Some of the sections could have been more damaged than initially expecting and contained non-viable fibroblast cells that are able to regenerate with the scaffold present. So if the fibroblasts were damaged in the dermis layer of the partial thickness wounds, growth factors scaffolding as well as remodeling could be inhibited, as these are all contributing factors that fibroblasts bring. The fibroblasts also control many things when it comes to wound healing, including the migration, extracellular matrix production, growth factor production, and protease releases, which will help with wound healing. Another potential possibility as to why these techniques failed was that perhaps the spray-on cells could have also disturbed the healing process of the dermis and caused cells present to be overwhelmed and not function properly. Further, the case study notes that there are openings with a lack of keratinocytes present. This could be because of an uneven spraying of the keratinocytes from the patient. The spray-on cells harvested from the patient could also have been damaged or destroyed while making the cell suspension, which would mean that there would be no effect on the epidermal surface when sprayed on. If the cells are damaged, the mechanical properties could have caused damage, so they would not function properly. Finally, another factor to consider for openings on the epidermal surface could be because the wound was not cleaned and prepped properly, because applying a spray on cells and the biodegradable mesh, you need to do a proper debridement. Otherwise, it will not take and it will not heal properly because you'll have dead tissue covering the tissue that's able to regenerate. The epidermis could have also experienced exposure that killed viable keratinocytes that can no longer regenerate when additional cells were sprayed onto the patient's skin. So there are ways to test whether or not the hypotheses that I have presented are a reason as to why the partial thickness treatment failed. So to test my hypotheses, I would suggest first running an in vitro cell viability test in a lab with the spray-on cells. So the cells would be harvested from the patient's skin and taken to the lab. This will determine if the harvested skin cells from the patient were damaged and destroyed before even spraying them onto the epidermal layer. Typically, this process uses the fluorescent microscopy, which you can see on the bottom picture on the slide. And it allows researchers to count the number of viable cells by lighting up or fluorescing. If the cells were in fact damaged upon transfer from the patient to the slurry, then this could explain why the wound healed irregularly. Another potential experiment would be one showing how evenly the biodegradable matrix dissolved over time. This would be a long-term experiment done in vivo that would be non-invasive to burn wound patients. So according to a study conducted in 2008, it is possible to study the degradation of tissue scaffolds via an ultrasound elasticity imaging. So if the matrix dissolves at various speeds, this can cause the microstructure at the dermal level to heal unevenly, which would lead to non-uniform healing. The non-uniform healing could in part cause openings on the epidermal surface, which could cause infection, cosmetic problems, or irregular skin contraction. Finally, I would like to test a small sample of cells collected from the wound area in the dermis to determine also if the area has enough fibroblast cells present to regenerate on its own or if additional wound techniques are needed, such as a graft. If the fibroblasts were damaged on the patient, then adding a matrix or mesh could prevent the wound from re-endothelializing evenly or at all. These experiments would determine cell viability and scaffolding, which would explain why the healing techniques